Oh, that was me.
Okay, it's unmuted.
All right, good morning, everyone. We are at the stakeholder meeting of the Texas Dental Board. Today is October 5th, 2020. It's 10:08 a.m. At the September 11th meeting of the board staff was directed to initiate possible rulemakings for one topic. And the topic is benzodiazepine doses, specifically what's acceptable for in-office and out-of-office administration, and existing provisions of the Dental Practice Act and board rules. And we will take comments in the order that we have received them. However, we will also let you stay in the Zoom meeting so that way we can have a discussion all together. And with that, I will hand it over to our Executive Director, Casey Nichols.
Hi, thank you, Lauren. So good morning, everyone. So as Ms. Studdard stated, from our September meeting, we were asked to conduct the stakeholder meeting. I just wanted to give those of you listening and those of you participating in our call today a little bit of background. We regularly in our anesthesia group receive questions from the public and from licensees about certain topics. I'm going to go over a couple of those common questions which led to us putting together the stakeholder meeting today. So one of the common questions that we get is for level 2 through 4 sedation permits, when does monitoring and documentation begin? Is it once the anesthesia is given? Another really common one we receive is, do you need a level 1 or a level 2 sedation permit to prescribe an anxiolytic medication, especially if you're combining it with nitrous? And then, let's see, that's paraphrasing some of the more common questions that we get. A lot of our licensees, it seems, have questions, especially when they're giving an anxiolytic medication to the patient the night before to take before the patient comes into the office, and about what level of sedation they need. Is this allowed? So we will be opening up the floor for discussion. And the first person that we had signed up was, Amber, are you on the call? Are you on this?
I see a David Roberts and a Texas Dental Association. That's the only 2 people. Or I don't know who Texas Dental Association is.
Well, that's okay. So we'll go ahead and let David Roberts go ahead. Dr. Roberts, would you like to give your thoughts?
You'll just have to unmute yourself.
You'll just have to unmute yourself. Dr. Roberts, you had requested to speak today, and the floor is yours. You'll just need to unmute yourself. There you go.
Okay, yeah, you guys had it so no one could unmute. I was trying to unmute, but you guys had it restricted. Sorry.
Okay. Go ahead.
So you know, I feel like the level of detail that the board may be trying to close the loophole on this, and when I say a loophole, you know, the rules can't be micromanaging every aspect of practice. And when you start drilling down to, you know, dosages and specific medicines, I think that you're opening up a can of worms that almost like there's too many subjects, and at some point, and it's too dynamic, and at some point, you know, the doctor has to be able to have discretion based upon the specific circumstance. And what was kind of telling to me during the meeting you guys had was that there haven't been any complaints or patient safety issues related to the sort of unregulated area of anxiolysis and what specific medicines can be given. But just as a general kind of thought, as long as the doctors are prescribing things that are allowed to be prescribed at home for home use, I'm not sure why that needs to be regulated. Now, if you're starting to add nitrous, then I think that's when you get into level 1. So that's generally my comment is as long as there's no identifiable patient safety issue that's on the table, then I'm not sure it feels like we're creating a solution to a problem that doesn't exist. Thank you.
Thank you, Dr. Roberts. So you're welcome to stay on the call if you'd like to continue participating in the discussion.
Thank you.
All right, let's see.
It's still just Texas Dental Association. Is the only other person.
Okay. Would a representative from Texas Dental Association like to go ahead and take the floor?
Hi, good morning. This is Diane Rhodes with the Texas Dental Association. The written comments that we submitted over the weekend are our comments for the purposes of this meeting, and thank you for the opportunity to provide feedback.
Okay, thank you. And just for everyone listening in, we will be providing all of those written comments on our website for those of you interested to review. Our IT division is getting those uploaded as we speak. All right, is there anyone else? Nope, okay. So we had a couple other requests to speak. It doesn't look like anybody else has called in yet though. So it looks like we have 3 other public speakers who are anticipated to speak. So once they join, we'll give them the floor. Is there anything, Dr. Henderson, that you would like to address?
No, I thank all the stakeholders for participating and submitting some written comments. I can certainly appreciate the widespread of discussion that we have had regarding this and where we're going to go with this. I'm happy to talk about like the TDA comment letter, just since it's the only one that we have written. So Diane, I find it interesting that in your letter of comment that you talk about off-label use of drugs, and if you submitted the Halcyon package insert, which nowhere talks about anxiolysis, although it is the #1 drug used in dentistry for sedation, minimal sedation, anxiolysis. And as you know, the ADA created this in level 1 sedation as an anxiolytic capture, but because of Texas and the way the statute is written, you don't have to have a level 1 to do anxiolysis. So, and I think that's where Dr. McNeil out of committee was talking about, should you have a level 1 in order to use a drug like Halcyon? And that's just where he was coming from when we decided to send this out to the stakeholder. So I find that interesting. I know you talk about not being able to regulate some other benzodiazepines. I totally agree with that. That Remimazalon that is out is actually for IV use, and it is a good for adult drugs, and certainly because it's a parental drug administration, I don't know that it has a big inferences. And you're right, you know, the dental board used to have a definition of anxiolysis that was obviously removed with this section, and I don't really know why, other than probably is level 1 is what they wanted to be anxiolysis and maybe be silent about it. So I do appreciate you putting Malamed's definition of anxiolysis back in as far as comment.
We have David Roberts. Yeah, David Roberts.
Okay. Would you like to? Did you
Yeah,
finish?
sorry, I have it set to where they can mute themselves now. Sorry.
Okay. Dr. Roberts, would you like to address what Dr. Henderson just said?
Yeah, I agree with Dr. Henderson that that Halcyon is not a anxiolytic drug. However, I do feel like it's appropriate for a dentist to be able to prescribe it as long as they're prescribing it in dosages in in methods that are acceptable in medical or dental clinical practice. And one of the key features is that in medical practice they don't give somebody Halcyon and tell them to leave the house. So I think that as long as the drug is being administered in the dental office, similarly as it's administered for home use, I don't see the need for monitoring and all kinds of special paperwork for that. So that's really the comment that I wanted to add, and I appreciate the time. Thank you.
Problem is that people are giving it at home.
Yes.
Yeah.
I mean, and they're giving it home, and it can be prescribed for at-home use. It's not that it's not safe. I mean, in fact, if you look at the history, the benzodiazepine dose response curve is so broad that really that's kind of where dentistry is, and loving it is you can give a lot and it really has minimal effect. The moment a patient is taking additional drugs, the potentiation of that could be significant. It could be the sleep medicine they take at night, Ambien, or it could be an tricyclic depressant of some other form. So, or even could be even Tagamet that changes the dosing of what a Halcyon is. And part of that is being a clinician and knowing that, and maybe not really regulating, but educating that we are allowing our licensees to administer this drug. But question is it anxiolysis or is it a sedation? And when does one drug become a sedation drug versus an anxiolytic drug, even though they have the same class? I think that's kind of where we are with this, because the Perio comment letter, and it was interesting that they posted that they feel all sedative drugs have to be administered in the office based on the rules of interpretation that they put in their letter. And I found that an interesting comment to decide, okay, if that's the way Perio feels, what do we want to say as when is that sedative drug administered, even if it's an anxiolytic? So I don't know that that was the only community of interest that made that comment.
So we have 3 other requests to speak but they're not on the line yet, Dan. Okay. Hi, welcome, Dr. Montgomery. Oh, he's connecting. Hi, good morning, Dr. Montgomery. Nope.
David Robert had his hand raised.
Okay. Dr. Roberts? Would you like to, go ahead.
Yes, I've had a couple people text me and say that they're trying to add comments and they can't unmute themselves. So I just thought I'd let you know. David Canfield's one of them.
Okay, thank you.
Canfield.
I don't see him logged in. Can Dr. Montgomery unmute himself?
He can, yeah. I have it set where they can.
Dr. Montgomery, our IT has made it so that you can unmute yourself if you'd like to have the floor.
But actually, I just joined the meeting, so I don't know what's been said, or I don't even know the point of this meeting. So, I mean, I don't know what to tell you. I sent in a fax letter that explained the problems I've been having with pharmacists and benzodiazepine prescriptions. So I don't even know what the point of this meeting is, like what the issues are.
Okay. We'll be happy to catch you up at another time.
Sure.
Dr. Steinhauser? Would you like the floor?
Yes. Should I just talk over him or?
Oh, no, he's finished. Go ahead.
Okay, he's still coming through my headphones. But anyway, I'm Dr. Steinhauer. I'm a pediatric dentist. I'm practicing in San Antonio, and I am speaking on behalf of the Texas Academy of Pediatric Dentistry. Yes. Yes, I'm speaking.
I think you have some reverb. Do you have do you have this streaming on another device near you?
I'm Dr. Steinhauer. I'm a pediatric dentist. I'm practicing in San Antonio.
Which one was talking?
Dr. Steinhauer?
If Michael can mute himself, maybe.
Dr. Montgomery, can you please mute yourself?
Can I do what?
Can you please mute yourself? Put yourself on.
Okay.
Thank you.
If I do it, then I can't.
Dr. Steinhauer, you should be able to speak with no feedback now.
No, ma'am.
Is there feedback?
Are you still getting feedback? Is that?
Okay, I can just talk and I can.
The YouTube stream running?
If you have the YouTube stream running near you, please pause it and just speak to us directly.
Okay, I'm going to start talking. I hope you can hear me and I hope we're in sync now. I'm speaking today on behalf of the Texas Academy of Pediatric Dentistry, and we have submitted written comments, and so I'm not going to go through all of that. What I want to emphasize is that our medical partners, colleagues, the American Academy of Pediatrics and the American Academy of Pediatric Dentistry, who set the standards of care for the treatment of children, both recommend, well, the standard is that you do not administer drugs to children for sedative purposes outside of the dental office. You should do a mini physical on the child before you administer any drugs to make sure there's no wheezing. Children have lots of asthma. You know, you don't want any sort of respiratory issues going on. You want to check with mom, make sure there's been no medication changes, all of this sort of stuff. You weigh the child, and then you administer the drugs in the office. That works good for pediatric dentists. It should be able to work good for all types of dentists. And so while we are not commenting on at all on how dentists and specialists would treat adults in their offices, and maybe this is acceptable on adults, but when it comes to children, we strongly urge you to separate children out from whatever rules you would come up with today, and that children 13 and under or under 13 or whatever, you know, wherever the board should choose to set that line, should not be prescribed drugs to take at home that potentially have sedative effects. And if you have any questions, that would be fine.
Thank you, Dr. Steinhauer. Anybody like to address?
Dr. Steinmeier, this is Brian Henderson. I just a question. So do I understand your feeling that it would be okay to sedate an adult patient based on your guidelines, your understanding and treatment, even of special needs patients outside of the office?
I wasn't really commenting along those lines. I'm not trying to comment on adult patients at all, but you bring up special needs, and that we do in pediatric offices. We often see patients with special needs, and we apply the same rules for them that we do for children. We bring them into the office, we weigh them, you know, we listen to their breathing, to their lungs, you know, all of this sort of stuff before we administer medications. If you have a special needs patient that you feel like you are not going to be able to sedate in the office, we take those patients to the hospital, and we have medical support for managing their behavior in the hospital. And I personally, would not feel comfortable giving them some sort of medication to take it home. An adult, let's say a 19, 20 or a 30-year-old special needs patient. That's, I would not feel comfortable with that. And I'm not sure that the Texas Academy of Pediatric Dentistry has an official position on that. So I'm not going to address that. I can tell you from my personal perspective, I would not feel comfortable letting them take it at home and then come in. What if it works? What if it doesn't work? Is the dosing right? Is it appropriate? Was the patient healthy? You know, all of these things, in my mind, all of these things still come into play. And it's a special needs patient. We know that they may not be responding as a typical adult. So, you know, quite often in our practices, we would take them to the hospital if their behavior is such that it can't be managed in the office, or they're not going to comply with taking a medication in the office once we've had a chance to evaluate them. Does that kind of get to your question, Dr. Henderson?
That's really kind of where I was going to actually lead you down the road to say, okay, what if you're sedating an adult normal patient? I mean, I know you're saying that it's pedo's stance at 12, 13, 7, 6, that number's all over the place, that the children shouldn't be medicated outside of the office. And you mentioned that you personally would not do a special needs outside of the office. What if you had that 14, 16, 18-year-old that needed to have some fillings done or a couple of extractions in your office before you send them to the general dentist? Would you sedate them out of the office because they're normal?
Once they get older, their response to medications is more predictable. There's an old saying, it's very gross, you know, I hate to even say it, but, you know, sometimes things happen, you know, sometimes shit happens, okay? That's just the way it is. And patients may have an adverse effect, or they may even die. Kids die faster. And that's just, everybody knows that. Every emergency room in the world knows that if you've got something going wrong, a child needs to be addressed immediately because they have no reserves. CPR has to be started immediately. The medications, everything has to be right now because children go bad very quickly. Now, on your healthy teenager, as you brought up, they're going to respond more predictably to any medications that you have. And if there's a problem, you'll have more time to address that. But I'm taking no position on that whatsoever. I mean, you know, years ago, you know, I probably did prescribe some medications for patients to take at home before they came in. That's not the standard of care anymore for the pediatric population. And I'm not going to comment on the standard of care, what should be the standard of care for older patients. I think it's, I've been on all of your discussions so far, and I know that you're faced with, is it dose related? You know, can we pick an appropriate dose that we don't have to worry about, that we can give? They can take it at home and then they can come in. If we just give them the right dose, well, you know, that's a very difficult decision, you know, especially if you can't see the patient. You're trusting that the pharmacy has dispensed the right amount of medication. You're trusting that it's the right concentration of the medication. Like on the benzodiazepines, you have Valium and you have diazepine and Tinsol, which is a much more concentrated drug, you know. So there's lots of things that can go wrong, and adults' metabolism can probably deal with those issues, but on a kid, no, it's just not safe to be doing that for children.
Okay, thank you.
I think Dr. Britton was just added to. Dr. Britton, whenever you get connected, we will give you the floor. Dr. Britton, thank you for joining us. The floor is yours. You can unmute yourself whenever you're ready.
See others, two other people.
All right, Dr. Roberts, do you want to go ahead and jump in while we get Dr. Britton straightened out?
I do, and I appreciate you allowing me to talk. I just want to make sure that we stay on the topic of areas that are not already regulated. For example, I think there might have been a little bit of overlap in Dr. Steinhauer's comments, because anytime you're giving, a medication above the maximum daily recommended dose, or you're giving multiple medications, those areas are already regulated. So it's my impression that this discussion involves, single drug, below what's considered regulated. And, I think your magnetic north is prescribing the drug along the lines of what's found in the package insert at or below the maximum recommended daily dose. And for example, I'm not sure there's a situation with respect to Halcyon individually, because it is kind of in a category by itself. I'm not sure there's a situation where the physician would prescribe Halcyon and recommend that the patient leave the home. So I think by virtue of that, that issue is already handled in terms of, if a doctor prescribes Halcyon to a patient and tells them to come to the office, and they have a problem, whatever that may be, however unlikely that may be, I think that's already something the board has discretion to sanction someone. And as Dr. Henderson said, if you guys are thinking that that's happening more frequently than it should, then rather than treat it with some sort of regulation, education and communication throughout the dental community is probably a better way to go. So anyway, that's my 2 cents about that. But let's try to keep the conversation below, what's below level 1, because I think that's the intent of this meeting.
Thank you, Dr. Roberts. Dr. Britton, we will give you the floor.
Okay, I still hear Dr. Roberts speaking. Is he finished?
I think that if you're streaming the meeting, then you are probably listening to the delay. He is finished. So if you can mute or pause the streaming and just speak to us
Gotcha.
directly.
Hello?
Yes, sir. We're ready for you.
Okay, I lost the meeting, but if you can hear me, that's fine. I wanted to first say thank you for letting us participate. And I heard Dr. Henderson comment on the Texas Society of Periodontists comment letter. I'm president of that society currently. And I just wanted to clarify that in our letter, we were stating that these medications already have an MRD from the FDA, which is their dosage for unmonitored home usage, and that we can give dosages higher than the MRD up to 1.5, but those dosages above the MRD need to be done by a sedation permit holder. So obviously that would be done, it implies that it would be done in the office based on the current rules and regulations. So I just wanted to clarify what he was saying in our letter.
Thank you, Dr. Britton.
Thank you.
Okay. Dr. Radwanski, the floor is yours. If you'd like to go ahead and unmute yourself. Last four digits are 5218. Dr. Moore.
There we go. Can you hear me? I'm sorry.
Yes,
yes, I appreciate the opportunity to visit with you all, and thank you for taking the time, Dr. Henderson, out of your busy schedule to hear our comments. But On behalf of the Texas Academy of General Dentistry, which has always supported regulations that protect patient safety, I want to speak in some of the things you've already heard, but I want to read to you what we will be following up with a letter. Over the past years, a number of steps have been taken to reduce risk, particularly to the high risk and pediatric patients when administering anesthesia and sedatives. To date, the Texas Academy of General Dentistry is not aware of any evidence that has been, is not aware of any evidence that there has been incidents of patient morbidity or fatalities attributing to prescribing or administering benzodiazepines for anaphylaxis, either in or outside of the office. Furthermore, under existing regulations, dentists are already required to follow the standard of care for all prescriptions, whether they're prescribed out of the office or administered in the office. Therefore, it is the Texas Academy of General Dentistry's position that there should not be additional regulations on prescribing of medications by Texas dentists. So I wanted to just affirm that we're opposed to any additional regulations. We think we've proven that this has been a safe, effective use of the benzodiazepines and over the years. And I think Dr. Bell also said that they haven't had any cases. So just to reiterate that, thank you for listening.
Thank you. So we wanted to open up the floor to Dr. Brian Moore. Dr. Moore, if you would like to unmute yourself, the floor is yours.
Hello, good morning. This is Dr. Brian Moore, and I was actually in queue if Dr. Wowanski was unable to join or to get unmuted. So I will, there's nothing more to state other than thank you and appreciate your time this morning.
Great, thank you, Dr. Moore. Anyone have any response?
I have a question. Is Dr. Britton still on the deal? Or maybe he wants to unmute himself.
Yes, sir. I'm still on the call.
I went back and reread your letter real quick, and I appreciate your comments. I find it interesting. And you throw out the MRD, and you're exactly right. Do I infer on this letter that you're considering one MRD as the maximum dose for at-home unmonitored use?
Well, I don't have it in front of me, but I believe that's defined by the sedation definitions in our rules and regulations.
Well, yeah.
Which is the dosage that the FDA publishes for unmonitored home use.
Yes. So it is a 1 MRD, and we talked about minimal sedation as being able to go to 1.5 times the MRD before it becomes moderate. So we kind of have that line drawn in the sand for those between 1s and 2s. And so, and I guess that's kind of where I was going with this question is, what if you don't have a permit at all? Can you still give up to 1 MRD on a patient with no training? And what you thought about that? Because that's where I was looking at this is when does that sedation become an anesthetic where in your letter you talked about you had to do it inside the office, and that was you're saying is a 1 MRD, is that correct?
What I was saying in the letter is just reiterating the board rules that if you're going to go above 1 MRD, you can go up to 1.5. However, you need to have a sedation permit. And that needs to be done in the office because it's implied that it should be done in the office because you're under direct supervision.
Okay, thank you.
Does that make sense?
Yeah, makes perfect sense.
But I think that if you're below the 1 MRD, then you're licensed to write that as the way the statute is written, for any medication.
And do you feel that-
Currently, is that not correct?
Yeah, I believe that, but that's my understanding. And so I'm asking you for any medication, even drugs that are off-label use, it would be okay, and combinations thereof.
Well, I mean, this is my personal opinion, but I don't think that at this point we've seen, as stated by staff in the previous committee meeting, that there's been a public safety issue. So without having any data to support a change in the prescribing recommendations, I don't see that there's a need to make a rule change.
Okay, thank you. Dr. Canfield is trying to get in.
Is he a phone number?
I don't know.
Yes, we do have.
Phone number just popped up. I was about the 0796.
Yes, that's him. That's him. Dr. Canfield? We are ready for you if you'd like to speak.
Sure. Can you hear me okay?
Yes, sir.
Okay. I appreciate the help from Dave Roberts and Dr. Henderson on this because I was having trouble getting in. I'll make this brief. I've written up a few notes. I do appreciate you taking the time to address this important topic because this comes up in my courses quite often in phone calls that I get. I've been teaching anesthesia in Texas for a little more than 34 years and practicing anesthesia on there. So the main area I'm going to address is the out of office dosing. And it may be a little contrary to what some people are doing, but first of all, one of the things I look at is what does the Dental Practice Act allow us to do as dentists? And this I addressed with the night before dosing and things. And the Dental Practice Act, my understanding is to provide something to provide for our dental procedures. If we administer the night before, we're not going to do dental procedures on them that night. And I find that from a phobic standpoint that we typically do not have that as an issue. My patients show up without having things the night before, and I have some pretty scared patients. So the 3 points that I want to address quickly here, one is whatever's going to be utilized, the definition of anxiolysis, out of office, or whatever dosing, it needs to be very specific to eliminate confusion for the practitioner and the educator. And this is something that I've run into in numerous states in that it usually ends up being kind of a gray definition, and that's why I think you're addressing this particular topic. The second is utilizing this definition. Particular drugs need to fit within that definition. So as an example, if we want to say we're giving a drug for anxiolysis, but it's not labeled as an anxiolytic drug, it doesn't fit that definition. So a drug like Trazolam, which is a sedative hypnotic, should not be in that. I can go into my general anesthesia where we use a drug like propofol as an example. And can we give it in small enough doses where people could be kept conscious? Certainly, but on my anesthesia records, I need to document that they were in a deep sedation the moment I give them that. So we need to make sure that things are specific for the drug. So as an example, we want that they need to be specific within what we're talking on there. Third, aside from any definitions, is patient safety. And this is where I really look at, and this is where I personally feel that all sedative or anti-anxiety medications, or however you want to label them, should be administered in the office setting only and have required training and a permit to administer these medications. I can give you a whole list of stories from individuals that have done my course that they've administered things outside and people have driven in, they've fallen, injured themselves, and different things like that. So in addition to proper monitoring should be utilized, and this can be done in the office setting. This is the teaching my programs. First, for several reasons. One, all individuals respond differently to medications. I'll use myself as an example. If I have a glass of wine in 30 minutes, I'm passed out. If I take a Benadryl for bee sting 25 milligrams, I'm not going to be driving in 30 minutes. People all respond differently to different things. What may be safe for one person may not be for another, and we can't really tell that. Physicians fit under a different set of rules than we do. Let me get on to here. That was my second point. Patients don't always follow instructions. Therefore, they may endanger others while under the influence. And then third, discussing this topic with course participants, I found this protocol is not an imposition to have patients come in, get their medications or whatever. Most of the time, it's an imposition on the practitioner that does not want to follow additional guidelines as far as monitoring or training and things. So I realize there might be some exceptions to this, such as treatment of chronic pain disorders. But in summary, out-of-office administration of medication can be a tricky endeavor, which needs to be a careful thought process. My opinion, based upon teaching and clinical experience, I recommend in any rule that all prescription benzodiazepines for the dental patient, outside of their normal medical treatment and unaltered doses, should be administered in the office setting with proper training, monitoring, and documentation, and probably of at least a level 1 permit, because we can't say whatever's anxiolytic is going to be not sedative. Thank you for your time. I appreciate that.
Thank you, Dr. Campbell.
Thank you, Dr. Canfield. As one of the old guys with you for a long time, what we do know, the benzodiazepine dose response curve is really very generous to overdosing and very variable situations. That probably why it shows that its use and safety has not been a problem as opposed to some higher doses of narcotics that have been released over the years. And so we keep dropping those doses. My question to you is, well, so what? You know, if we have a variable response, if we have an adult patient that maybe it gets a little too intoxicated because you thought a 0.5 milligram was the appropriate dose and it really should have been 0.125. Do you think there's a problem if you told them they needed a ride, they needed someone to bring them, et cetera?
I think I have a little lag on here, so hopefully I'm not talking over you on this.
No, go ahead.
I think where we run into the situations, and I think practitioners are setting themselves into a situation they don't realize, in that if that individual takes a medication and maybe it's as an anxiolytic, because with anxiolytics, the physicians will allow patients to drive, but we fit under a different definition. We're not doing it every single day. If they go out and they have an accident, it's going to be traced back to the practitioner, and that's going to come in there. And I think it's probably maybe not appropriate for me to say, but I think if the board sets certain parameters and they're following those, and those end up being a problem, then it's going to come back and look at the board also on what parameters were set.
Okay, so you think, would it be reasonable if the board was to write some parameters that they would stay with the more traditional anxiolytic drugs for those people that didn't have a permit, such as Valium and Cerax and Xanax, as opposed to allowing them to give Halcyon?
Well, I think Halcyon would be pretty much out of the question, because it's not an anxiolytic drug. It's not labeled as anxiolytic. And if you look at some of the literature by Joel Weaver and individuals like that, they basically say it doesn't have any anti-anxiety properties. With the other drugs like Valium and Cerax, I think that's where we run into the issues, because what is going to be anxiolytic for one person is going to be sedative for another, in trying to go with that.
Difficult to predict before you give the first dose is what you're trying to say. So would it be reasonable to say, if you were a dentist and you were going to see a patient 4 or 5 times, then maybe the first dose needs to be done in the office, and depending on how the response was, if it was minimal or negligible, or it could be documented, the subsequent doses could be given at home?
I mean, I think that would be a decision for the board to do that, but I don't think it would be unreasonable to, at least for that initial dose, require them to have it when they come in. As you know, as I mentioned, like with myself, I weigh, well over 200 pounds, not well over, but, and I'm very sensitive that I haven't taken Valium, but by my dose of 25 milligrams of Benadryl for a bee sting, I would suspect at 5 of Valium, I would be pretty well incapacitated.
Okay, very good. Thank you, Dr. Canfield.
Thank you for your time. I appreciate it. And thank you for taking this meeting and for all the other input.
Anybody else left wanting to speak?
I don't think so. Anybody else asked to sign up?
I think it said something a little while ago, like 5 minutes ago.
Asking to speak?
Submitted in
Okay, we're working to get possibly one more speaker who would like to comment on the line.
Yeah, he should already have the information.
So Dr. Evans, if you are listening to the live stream, our IT division has sent you the login information for Zoom. So please feel free to log in so that you can make your comments. That was Dr.
Evans,
Chad Evans. If anyone has any additional comments that they'd like to make in the meantime, please feel free.
Raise your hand and we'll call on you.
Yep. Again, Dr. Evans, if you are listening to the live stream or watching, our IT division has sent you the necessary call-in information to participate in the Zoom meeting. If you would like to log in.
Send it to him again.
Okay. Give him another minute or so, but Dr. Henderson, do you have any other comments or suggestions that you'd like to make, or?
Yeah, I mean,
No.
we could go into a lot of discussion, but not probably. I think we covered the topic that
Right.
stakeholder was setting rather than getting off topic.
Sure, okay.
But I do appreciate everybody giving us input. And I'll certainly take back to the anesthesia committee to see where we go with any comments. I don't know that we're trying to write rules just to be writing rules.
Right.
And maybe we need to eliminate some rules. You know, at one time I considered saying that maybe a level 1 permit really doesn't, it's redundant in Texas. Maybe really don't need a level 1 permit. But I can see now that there's enough people that feel that they need to have a level 1.
Wayne has his hand raised.
Who has the hand raised? Wayne?
Brad, yeah.
Doctor?
Dr. Red, go ahead.
Yeah, just a comment from Dr. Canfield's, you know, and I respect him. I think he's pretty well respected all over. But my question to him would be, and others, is have we had any problems in the past with the benzodiazepine? And, you know, are we digging up something here? We don't even need to go down there. I think that's been said over and over. And so, I mean, we could make up all kinds of scenarios. This could happen, but bottom line is it hasn't happened. So I just say, why create something? Why create a regulation that's not needed? So that's all I had to say. Thank you.
And it looks like Dr. Evans joined us. Dr. Evans, the floor is yours. If you'd like to unmute yourself, please go ahead and speak.
This is Dr. Evans. Can you hear me?
Yes, please go ahead.
Okay, thank you. Yes, you know, I'm not going to waste everybody's time. I really echo a lot of the sentiment that's being expressed. You know, I am a sedation level 2 provider. I've been a sedation level 2 provider for years. I oversee probably 50 dentists that all have their sedation level 2 sedation certification. Cumulatively, we performed, you know, tens of thousands of sedations. I've personally performed thousands of sedations. I'm pretty familiar with this process and what it looks like. I mean, I know the difference between a patient that's been sedated and a patient that's been given medication for anxiolytic purposes. I think most of us on this call and most of us who have participated in this space know the difference between those two. I guess I'm just mostly echoing some of the sentiment that's been felt. There currently hasn't been a public safety issue related to this. We just spent the entire last year rewriting, redoing the entire sedation certification process and levels and inspections and, facility inspections. And, we just visited this entire spectrum of the way that we practice here in the state of Texas. And now we're one to go back in and on something that hasn't even produced any, negative public outcomes. So I guess I'm just kind of in that camp of I don't see a problem here. I feel like the board is adequately has plenty of power and regulatory power and oversight. Y'all know what a sedation is versus an anxiolytic dosing of a medication. And I feel like the board probably has all the tools that they need to address this. So that's the extent of my comments. I've also submitted something in writing, but thank you so much. I appreciate the time and opportunity.
Thank you, Dr. Evans. Interesting, I have a question for you. Since you say you do level 2 enteral sedation, does that mean you only administer medications in your office?
Correct. When I'm providing a sedative dental treatment, I keep all the medications in the office and all my dosing and administration is done in the office.
And do you do adults and children?
Correct. I do it both adults and children.
And do you have any thought process of whether someone should be medicated with, say, Halcyon outside of the office?
I think it's a difference between whether that should be regulated versus, what I'm doing in my practice. I'm looking for a level 2 sedation, which is certainly different than looking for an anxiolytic administration of a drug. So, at the dosing levels and the combinations that I'm using and the level of response that I'm looking for, I certainly would not dispense or ask anybody to do that outside the office. If I were just looking for an anxiolytic effect on some of these medications, diazepam, or I hear Halcyon being used quite a bit, that would be a different story, but that's not the way I practice. I'm sedation level 2 certified for a reason. That's my preference. And so, the way that I'm sedating, I certainly would not do that to, have anybody take those medications outside the office.
Thank you. Anybody else?
All right, we can wrap it up if. Okay. It doesn't appear that we've had any more public comments or anyone who's requested to speak directly today. Unless anyone has any other parting thoughts or comments or suggestions, we will open up the floor for next 30 seconds or so, see if anybody has any parting thoughts. Otherwise, we will wrap this up, and I'm sure this conversation will continue at our next Anesthesia Advisory Committee meeting, which right now is tentatively scheduled for December 10th. Should we do it a day before?
Okay. Nobody's hands ready.
Nope, I don't see. All right. All right. Well, we thank you all so much for your participation today. I'm sorry I misspoke before. Our Anesthesia Committee meeting will be December 10th. So if anyone has any questions or concerns and didn't feel comfortable speaking or didn't get a chance to speak, please feel free to reach out to the board and we will submit your comments to our board members in our anesthesia. Thank you all so much.
I'm not sure if I'm unmuted or not, or how to work this.
Oh, go ahead. All right. Well, we thank you all so much for your participation today. Dr. Canfield, if you'd like to speak, go ahead. Feel free to reach out to the board.
Sounds like it's a stream gone, but I also saw he just commented on the YouTube stream saying he's trying to connect but doesn't think we can see him.
Dr. Canfield, if you can,
sorry.
If you pause your stream, you can
one of these things here. I hope I'm not talking over on anybody. Okay. Now I can, I just one quick comment on there. As far as the benzos, and it's come up as far as their safety. And yes, I agree they're very safe drugs, but we have to look beyond the safety of the drugs. And I can bring up 3 cases right now that I'm aware of. An individual that took one at home, fell on his head on the sink. Another individual that decided in and that. And I think we have to look beyond just the drug itself, but the labeling and things such as not to be, may cause drowsiness, may cause issues with typing. And that's kind of a lot where I look at dosing that to help protect ourselves and the patient. So just addressing, I agree that safety it has a very good effect, very good history, but looking beyond that, I mean, anesthesia in itself is very good history on there, but we still monitor patients too. Thank you, and I'll be quiet after this. Appreciate it.
Dr. Canfield, before you go, I guess what I hear you say, and it's kind of an interesting thought, you think these cases that are occurring where someone fell, bumped a head, or had an accident are not being reported to the board, so therefore we have no idea really what's going on as far as out of the office use, because that was before the dental appointment started?
Right, it was before the dental appointment, and I don't know as far as any reporting on them. One was actually, a couple of them have been by individuals that were involved with that. Another one was by one of my colleagues that patients was involved in that, or he received a phone call on that too. So I'm not sure what they report to the board, where it was supposed to go. They didn't require hospitalizations, my understanding, so I don't think they were reported to the board on that, but I'm not sure.
Because those are interesting points, right? If you get involved with an accident or you run over somebody, that's not necessarily a hospitalization, right?
Right. One of the things I throw out, and this is kind of off on a tangent, which I tell my people in the class to say, if you want to consider something as an anxiolytic, take the drug yourself and then sit down with your next patient and say, hey, by the way, you were coming in, so I took this medication. How do you feel about that? And see what their response is. And I say, if their response gives you a negative response, then you probably should not be giving that to them outside the office.
Okay. Thank you, Dr. Canfield.
Thank you. Have a good day. Appreciate it.
All right, thank you everyone for your time. And again, if you have any additional comments, thoughts, questions, concerns you'd like to submit to the board, please do so. We will be happy to forward those comments onto our board and committee members. Thank you all so much for your time and your participation today. We really appreciate it.
Yeah, thank you.